I'll start, sir.
Please start.
Good morning, everyone. So this is the first paper which we'll be discussing. So it is the effect of age on radiographic outcomes of patients aged 6 to 24 months with developmental dysplasia of the hip treated by closed reduction. And this is a paper from China. And the aim of the paper was to compare the rate of redislocation, the incidence of AVN and final radiographic outcomes in DDH patients of different age groups managed with closed reduction. It's a level 3 evidence paper. And what they did was they retrospectively reviewed around 525 patients who were diagnosed with DDH and treated with closed reduction and spike application between 2004 and 2015. And they include late presenting DDS, that is between 6 months to 24 months of age, and who had follow-up of at least 24 months. And they excluded those with incomplete follow-ups and with neurological conditions. So finally, they could get around 276 patients who met the inclusion criteria. And closed reduction and arthrogram was done in all the cases. And abduction spica was applied for 3 months, which was changed in between at around 6 to 7 weeks. And in all the cases, post-operative MRI was performed after 48 hours to evaluate the reduction. And abduction brace was kept for additional 6 months after cast removal. For 3 months, they kept the abduction brace throughout the day, and for the next 3 months, night brace was applied. Coming to the results, they had 276 patients, of which most of them were girls, that is 241 were girls, and 244 were unilateral cases. And average age of the patients were 15.3 months. And prior to reduction, the acetabular index was measured on the AP view, and hip dislocation was also evaluated on the AP view based on the tonus grade. And what they found was the tonus grade actually it increased with the age. So they classified it into the cases into 3 groups. That is one less than 1 year, 1 year to 18 months, and 18 to 24 months. And what they saw was the pre-acetabular index and also the final acetabular index after treatment. They were almost comparable in all the age groups. And in all the age groups, they saw that there was significant improvement. And the redislocation rate increased with tonus grade. So the rates of redislocation, again, these were also similar in all the 3 age groups. And out of the 308 hips, 36 developed AVN, and most of them were type 3. And again, in AVN, there was no correlation between the age and the grade of AVN. And coming to redislocation, 17 hips underwent open, they had to do open reduction due to redislocation. And of them, 13 had satisfactory outcome in the final follow-up. So age at the time of closed reduction was not a risk factor for redislocation, AVN, or even poor radiographic outcomes according to the severance grade. So what they concluded was the age had no significant impact on redislocation, the AVN, and final outcomes in the late detected DDH cases treated with closed reduction. So many of the papers usually, again, in the age group of 18 to 20, they showed that even in that age group, it doesn't significantly differ by doing closed reduction. And the only thing which was significant, which was seen, was that the main factor associated with redislocation was the severity of the redislocation according to tonus grade. So higher the tonus grade, there was more chance of redislocation. And coming to the limitation, it is a retrospective study. The paper is now open for discussion.
So, as all papers coming from the Oriental country, this has a huge numbers and a very specific study. The only issue is what are the learning points, Varun, of this study? What do they conclude, or what do we learn out of this paper? Uh, that's the question. Is there a message you got from this paper after reviewing it? That how would your practice change as far as close reduction of hips is concerned?
Yes. So only thing I think which is significant, like after reading this paper, is again between the age group of 18 months to 24 months, we can always opt in for close reduction than open reduction. And the other thing is like if the tonus grade is high, then because chances of redislocation is again high, so the parents can be adequately be counseled regarding if we see a case with higher tonus grade, then they might require surgery in the future, though we can give a trial of close reduction.
Okay. So anyone in the audience wants to comment on this?
Yeah. See, I don't think there's any message in this paper at all. I mean, other than what was stated, is that you can tell the parents that the rate of redislocation is higher statistically if the tonus grade is high, regardless of age. But then, I mean, why mention that fact anyway? Because what would you have done differently is the question. So I don't think it really. So because if you get a successful close reduction, even at 24 months of age, and your arthrogram findings support the fact that you've got a stable and secure reduction, I would still go with a close reduction. So, I mean, and I know that, there is always a chance of redislocation. So what? Does it change my practice today? I don't think so.
Right. So there are a lot of unanswered questions, in this paper. One is after 1 year age, what? Even if you get a close reduction, would you still open? Because there are many risks which are associated with doing a close reduction after walking age. So many of them will have redislocation, and more important is risk of AVN. Many of these patients will have changes in the anatomy of proximal femur and acetabulum, and will they require a secondary procedure? So it's a very interesting subset of people, and even we are studying it. Results of close reduction after 1 year age, and what happens to them in long term. And it would have been interesting to see, what is when you compare it to results of open reduction in this age group, and which is more than 1 year. How would results of close reduction change?
So what we should do really, Taral, is if we are going to back up our suspicion, what we should do is we should have an age cutoff, say 12 months or whatever.
Yes.
Some age cutoff we should have. And then in children who are older than that age group, you should, even if you have a successful close reduction, according to arthrogram, you should then open the hip. And you should do an open reduction and show whether even with a successful closed reduction, you went ahead and did an open reduction and you reduce the rate of AVN, because that's what we are trying to, and reduce the rate of redislocation. So because that's what we are trying to do. So is to reduce the rate of AVN, and our suspicion is that in older children, if we do a closed reduction, that we may get a closed reduction, but the AVN rate is high. So that's the only way in which this thing really can be resolved, satisfactorily. Otherwise, this question will just drag on forever. And we'll
Just
never get
quickly a sentence from the conclusion. It says that patients with late detected DDH, aged 6 to 24 months, can be treated with close reduction. So I just want to sort of counter this statement. I want to ask Avi, do you agree with this statement?
I don't
As a
agree
first thing.
completely I do agree with some of the things Jayan sir said, but like the recently also we discussed couple of papers as to role of imaging, higher imaging in these older children like MRI and the certain signs which might let us know that will close reduction help or will this end up having open reduction. So I feel in these older children we might have to even think of like an MRI, like we had discussed a paper about MRI, certain findings which will tell us that our close reduction will fail. But eventually, it's a on-table feel. If you feel you have got it inside without much tension, then we might go with it and see how it works. But it's very difficult to say if you have got a good close reduction and then you open it as well. I mean, we'll have to see.
So they will not specify, yeah, in this subset of patients, did close reduction fail in any, how many number of patients? So if you have 100 patients, in how many of them they tried a close reduction, it did not work and had to do open reduction. So probably this is just a subset where close reduction was achieved
Yes.
and they're looking at results of that.
Yeah.
And that number is going to be less, as the child becomes older and older. Okay. So let's come to the next paper. Avi, yeah, you can start.
Good morning, everyone. Uh, So this is another paper from China. So it was quite interesting. They've used a new technique, relatively new technique for the treatment of multidirectional unstable supracondylar humerus fractures. So it's a level 3 retrospective study. So as we know, multidirectional or Gartland type 4 supracondylar fractures are a little tricky to treat, and they are unstable in both flexion and extension, and traditionally it has been difficult to do the regular close reduction technique. So their aim was to basically modify the close reduction technique by using a transolecranon pin to achieve temporary stabilization. So between 2012 to 2018, they identified 35 patients of this variety and divided them into two groups. Group one was having 23 patients where they did the regular technique which majority people follow, that is close reduction and pinning. And group two, where they had 12 patients
यही दवा देता हूँ खत्म करता हूँ
uh, where they tried out their new technique.
छोड़ मत काय को
And
पेड़
the
बड़ा
minimum follow-up was around 16 weeks. So they selected patients which were no, which were non-comminuted, no open fractures, no neurovascular injuries. So they were straightforward injuries. So this is their basic technique. So they took the child on in a supine position, and they used the semi-sterile technique, which has been discussed by a lot of our American papers. And the shoulder is taken right till the edge of the table. The thing that they have is that they use a G-arm, which gives you orthogonal views at the same sitting without moving the X-ray machine. So first is they did a gentle uh, reduction. They saw the all the views of the elbow to make sure it is a type 4, and then they did a gentle reduction first in the lateral view, and then flex the elbow to around 90, and then pass the olecranon pin from the olecranon into the distal part of the humerus. And once they confirm that it is completely reduced in the lateral view, pass the pin as like an intramedullary wire into the proximal part of the humerus. Then they focused their attention little bit on the AP view, as now they said that since the pin is intramedullary, it will not cause too much of displacement. So then now they corrected the fracture in the AP view, and then they fixed it in the regular fashion with the lateral pins, and at the end they removed the olecranon wire. So basically they followed up most of their patients till the age of 2 years. So there were around 26 males and 9 females, and the average age of their patients was around 7 years. So what the surgery was done pretty much straightforward around 10 hours after the injury in group one, and
6
around
lakhs
11 hours
and
after
63 times as well
11 hours after the injury in group 2, which was fairly similar. But the main comparison, what they found is when they compared the groups, is they both had good and almost comparable clinical outcomes. But they saw that the surgical time was drastically reduced with their technique compared to the original technique, and also the amount of fluoroscopy or the time of fluoroscopy was drastically reduced with the new technique. They also correlated that they had a slightly better Bowman's angle, that is better correction in the AP view with the newer technique as compared to the original close reduction and percutaneous spinning. But overall clinical results at long-term follow-up and arc of movement was pretty much comparable. As such, they did not get any complications except for one superficial pin track infection in group 1. So overall, they said that this is a stable technique which will help reduce the surgical time and the fluoroscopy time and can give better reduction without increasing the risk of complications. So there are limitations because it's a retrospective study. Secondly, the patients are not randomized. The other is there were multiple surgeons, so there can be variability in technique and timings. The other is it is conducted from a single hospital, small number of patients, which is quite limiting, and it's a larger number would have been better. And also they have not mentioned about which patients ended up if they did not get the reduction, did any of them get converted into open reduction or any other technique was used? And thank you. So now the paper is open for discussion.
Yeah, very nice paper and well presented. I really like this and never thought of this. Something which I'm going to keep always in my armamentarium, and if other things fail, I don't mind using this technique. What I find advantage of this technique will be in very low supracondylar fractures, or sometimes in transfascial separation where you don't have something to hold the distal fragment. And here you will have a pin which goes through the olecranon, so it will have a good hold, and it can give you direct access to traction, correction of translation, and as well as flexion and extension. So I feel, this in combination with a joystick, which is wire which is put from laterally, so two wires, I can use as a steering group and get a reduction. So has anyone used such a technique from the audience at any time?
It's well described for flexion type supracondylar fracture.
Okay.
So this is my standard technique for flexion type supracondylar fractures.
All right. You pin through olecranon and correct that.
So they have used this now for multidirectional for type 4 fractures.
Okay. The only sort of a downside is you are going through the joint. Because since they remove the pin, I don't think that should matter much.
Sir, we regularly use a temporary pin, so I don't think just passing one pin without too much should cause any issues with the joint. The only thing is they used a G-arm, so they had an advantage of technology because with the G-arm you can have AP and lateral without moving anything. We use a C-arm, so that we just have to move the C-arm for us. That's the only thing.
Right. Absolutely. So, any other sort of questions or comments from audience? All right. So, I think one more good learning for a Tuesday morning, and good to know from Jayant that in the flexion type, this has already been described, and he has used. Have you been happy with this, Jayant? You feel that this would add to your
Absolutely.
Okay.
Absolutely. So in relation, so the other technique which is used for flexion type supracondylar is the so-called push-pull technique. So push-pull is just a way of manipulating a flexion type supracondylar fracture over a roll. So you're keeping it in neutral position in it. But the transolecranon pin really gives you a lot of stability because otherwise it's wobbling all over the place, and there's a lot of soft tissue swelling in these relatively high energy fractures. So I think putting a transolecranon pin just stabilizes things, just makes it manageable, so that at least you can get your first pin in, and after that gradually you start to get control of the fracture. So it's a very useful technique, I feel. Just to get an initial bit of stability.
So only question I had was, then you have no control over elbow flexion or extension. Once you put this pin, many times. The question is that if you need to put a medial pin, what we do is, initially we put lateral pin in flexion and then extend the elbow and put the medial pin. So I guess, with this.
So you can
remove
remove the
this pin and
transolecranon pin as soon as you've got the first pin across the fracture site.
yes, and then
You're
put
able to
rest
remove
of
this
it.
pin. Yeah.
Absolutely, great. So if there are no other suggestions or questions, let's move to the next one. Amol, please share your screen. He's going again another interesting paper, and these are all different topics today. I think I must thank Varun for choosing, topics and papers which are little out of the box, and really happy with this. So this is from Shiners. All right.
Hello. So this topic is end-to-end gait in children with clubfoot and the effect of tibial rotation osteotomy. This was done in Steiner's Hospital, South Carolina. It's a level 3 study and as a retrospective one. The study begins with the overview of telling us that the end-to-end gait is a common sequel in both in both non-operative and surgical treatment in patients with idiopathic clubfoot. And the what contributes to this end-to-end is the residual or recurrent foot deformity or long bone malalignment of tibia or multi-level gait dynamic deviations at higher level of pelvis. It also states that gait deviation in associated with clubfoot is usually due to a decreased range of motion at the ankle, a decrease or internal foot progression angle, and reduced power of ankle plantar flexion. There are also transverse plane deviation including in-toeing gait pattern like internal tibial torsion and foot adductors, which has been reported in up to 70 to 80% of patients with recurrent clubfoot. The goals of this study were to identify the primary and secondary gait deviation associated with the in-toeing gait pattern in children and using pre-operative motion analysis and the efficacy of their intervention at 1 year follow-up and determine if there are secondary mechanisms have normalized of hip and pelvis after the restoration of the transverse plane axis in the lower limb. This study included 19 patients. All in the inclusion criteria was a diagnosis of clubfoot deformity. They did a pre-surgical gait analysis in every patient. The mode of treatment was unilateral or bilateral distal tibial rotation osteotomy for correction of an in-toeing gait, and also they did a post-surgical gait analysis. The indication were again a clubfoot deformity and in-toeing gait with functional complaints of tripling and falling during activities. Clinical examination also suggests an internal tibial torsion, and they also relied on a kinematic evidence of internal FPA and increased internal knee rotation. The data measured in the studies were firstly from clinical examination they collected femoral anteversion, tibial torsion like bimanular axis in flexion and extension, thigh foot axis and ankle plantar flexion strength. From radiological perspective, they did AP standing and lateral standing and measured all angles like talus, first metatarsal, talonavicular coverage angle, calcaneal pitch, and tibiocalcaneal, talocalcaneal angles. They did dynamic and static postural gait analysis. For clinical data, they relied on the course of the treatment for CTV prior to TRO and incidence of post-TRO interventions and family satisfaction. The results of this studies are that as far as tibial torsion is concerned, from internal rotation of thigh foot angle -8 to it was changed to 11 degree, and bimanular axis were also from 9 to 3, 8 external rotation were changed to 38 and 23 in extension and flexion respectively. The hip rotations were not much affected. Neither did the ankle's great strength, the dorsiflexion and plantar flexion strengths were not affected by this procedure. Also, the ankle range of motion was not affected. Only tibial rotations were affected. Again, as when they measured the radiographic analysis of the X-rays of foot, the angles were not affected much in pre-operative and post-operative period. As in kinematic study, foot progression angle was improved and a knee rotation study was improved. The discussion for this paper was that torsional alignment can present in a significant variability in patients with clubfoot deformity. The study indicates that internal tibial torsion and associated with pain are present in these patients, and after correction of tibial torsion in patients with club feet, the results are similar to patients with idiopathic tibial torsion. The limitation in the study is that in certain patients secondary hip rotation were overcorrected by the TRO. Second potential weakness is that this study included only those patients who went for corrective osteotomy, and no other control group was selected as patients who did not went TRO but had residual entowing, and their follow-up was not continued as another line of treatment was not evaluated. Third, all the parameters that they presented were only radiological or data measured, and no patient satisfaction and no patient clinical like functional parameters were presented at the end of the discussion and the paper. So we do not know that if the this surgery, if the data change in data or change in the angles or 3D gait analysis affected the patient's well-being or functional ability. uh, Thank you. This session is open for discussion.
So good paper. Again, I want to ask the audience, in how many patients with clubfoot you end up actually doing a tibial derotation osteotomy? I have done in less than 10 patients, and then the number has increased after we've done gait analysis for these patients and also CT scans. Because there are patients, with good correction of the foot still walk with entowing, and that needs correction. And, a combination of gait analysis and CT scan and clinical evaluation may be useful, but the number doesn't seem to be so high in a clinical practice. Rajiv, I wanted to know from you, in how many of your patients, you have actually done a tibial derotation osteotomy for persistent entowing with clubfoot in clubfoot patients?
Only one.
Only one. Yeah. Jayant, so Jayant is saying very few after Ponseti's method. So does Ponseti's method, because we give external rotation, is that insurance against tibial torsion? Does it correct tibial torsion? We really don't know. Yeah,
I think so. I think so. Even though Ponseti, one of the things that Ponseti said was that there was iatrogenic external rotation of the tibia with the old kite method.
Okay.
And he said there was over external rotation of the sort of tibiofibular angle. And Ponseti actually said that with his method, you didn't get that iatrogenic external rotation of the fibula. Excessive external rotation of the fibula. But I actually feel that, having done Ponseti and having seen some of these older children before the Ponseti era, I feel that somehow this internal tibial torsion is also getting corrected during Ponseti method when we apply particularly when we do the below knee cast, we are putting head on the pressure on the talus, but when we extend it to above knee, we are doing some external rotation of the whole leg. So at that time, I think some more remodeling might happen. So it's not been studied very well. Maybe if you're doing some sort of CT torsional profile in children with who have had Ponseti, it would be useful, good to look at it.
Okay. Any other comments on this paper? Okay. So I'm just seeing the chat box. Yeah, very few after Ponseti, and Rajiv is saying only 1 in 1,500. All right. It will be worthwhile looking at the gait effect, but I don't think it's a big problem. But I remember few patients who do have persistent tibial torsion. Some of them even have angular deformities, and that sometimes need to be corrected. All right, we go on to the next paper, which is again a very interesting sort of a concept. This paper has come from China and deals with a very interesting subset, DDH in children above 9 years. So there are a few things which got me interested in. I selected this paper as soon as the list was put up by Varun. Was that of course it's a large number of patients, 22 patients they have treated of 9 years, some of them bilateral, some of them unilateral, and all of these were treated by open reduction, femoral osteotomy. But what they did to acetabulum was something interesting, and I'm going to describe to you in a while. They use Mackay's criteria for clinical grading and Severin's grade and the routine radiological parameters to evaluate these patients after the surgery. None of their patients had redislocations, and you can see from here that most of them, at least 50% of them, seem to be doing fair from Mackay's criteria, and rest of them have got good and excellent results. So none of them are doing poorly. So it was sort of a fear that if you operate a child above 9 years with DDH, and you will end up with a bad clinical or radiological result. So this paper sort of, corrects that myth that you should not operate a child above 9 years with DDH. So these are two things, which got me really interested in the method which they have used. Now, the downside of a paper which comes from that part of the world is they're not very good with English or describing. And this method, which is so good, has not been described at all in the text. When they're describing material and methods, they had a good scope to describe this method step by step. But, I had to read this article 4 times, and then I went through the diagrams, and I thought I have understood what they are doing. So what they do is, after doing open reduction and femoral osteotomy, they look at the acetabulum. And what they have done, initially they do, acetabuloplasty, something like Degas osteotomy. And having done that, after that, if they feel that if the femoral head is not covered, then they go ahead and do triple innominate osteotomy. Okay. So it's a combined procedure, two acetabular procedures done at a single sitting. So that is something, sort of you can see now in the post-op X-ray, how well the acetabulum is covered here. So this is something which is interesting, which I got from the paper. Now, from what they've described, again, I found this very interesting kind of instrument where they are measuring the derotation of the femur. So it's like a goniometer, which is used intra-op to determine how much of femoral derotation you're going to do. And I'm going to take this idea and probably use in future to see, whenever we are doing derotation osteotomy, can we measure the derotation? Last time we had a paper where femoral derotation osteotomy was done using pin and plaster technique, or Jain mentioned about pin and fixator technique. And I want to know if this sort of device can help us in that. Okay, so these are their result, radiological outcome, and you can see that the CE angle, from -24, it improved to very good 43. So which is a very good sort of a correction. Acetabular index also improved from 43 to nearly horizontal acetabulum, and then migration percentage improved from 79.6 to 0.7. So which means all the hips were very well contained, and they were doing fine. So okay. So I want to show some of the results which they have shown. So here you see a child with DDH. This is more than 12 years of age, and what they have done, again, this diagrams depicted, the text doesn't depict it. So they do a very low Degas, going down, almost close, kissing the acetabular subchondral bone. And then after that, they have done a triple innominate osteotomy. And you can see that, beautiful coverage of the acetabulum, and this is postoperative range of movement of the patient, which also I feel has been pretty good as they have achieved it. So this is a paper where good points about this paper are that it's a good technique they have described. It's a specific cohort of patients. They have described radiological features very well. The downside of this paper is that this technique has not been detailed very well. So what I'm going to request to one of the younger people, the fellows here, is to write to the author and ask them to describe the technique, and maybe we can invite them on POSI or IFICS platform sometime to actually talk about their method and results, and we can all learn from that. So this is now open for discussion. I want to ask people in the audience, if have you done this before anytime? One was Avi, Jayant, people who are interested in hips. What would be your take on this?
I need to read the paper to look at their technique.
You won't be able to read Jayant, if you read the paper, you won't get anything. It's very simple. If you read the paper, you won't get anything because they have not described anything.
Yeah.
Not a single line on the technique, not a single line, not even in discussion.
So that's not very helpful because we need, so the combination of triple pelvic osteotomy and open reduction in older children is well described.
Yeah.
But these are all they're all
Yeah,
two
but
surgeon operations.
so they've added an acetabuloplasty. So they have changed the slope and changed the direction, both. So double osteotomy of the acetabulum.
And the ischial cut is done through the femoral osteotomy incision. Like you said, they have not described any of that, is it?
Yeah, we should talk to them. We should write to them and find out.
Okay.
Avi, what's your take on this? Any comments from you?
That also, like, I'll have to read it once, but I have seen people doing Dega and then later adding a triple, but not at the same time. I don't think I've read that or seen that. But my take is, if you're going to do a triple, anyways, it is powerful enough to do everything. So, do we actually need the Dega as well at the same time?
Yeah, because with triple, sometimes you don't get that. You sometimes need to rotate it too much to get that anterior support.
Yeah.
So this will limit the rotation, and then you end up doing over correction. One more question I had, looking at the X-ray, is the risk of FAI in these patients, because it's really over corrected. It's not just corrected.
That's what. So, I don't think you need to do this. Maybe in everyone, it might be required in some selective cases with really high dysplasia and things like that. But I think you have to decide based on the acetabulum on an individual basis.
Yeah, I agree. So they start with acetabuloplasty, and if that is not adequate, then they do add up a triple. So that's what they have described. So that's one line which is mentioned somewhere, which you really have to have binoculars and or microscope and hunt for that line in this paper. This again. So I think when you review a paper, just one casual reading is not enough. You need to read it 2 or 3 times to get some hidden meanings and look at the pictures carefully to get more out of that paper. Okay. So Jayant, over to you for the last paper of the morning.
So this is a paper from Turkey, published in the JPO. And they are looking at the discrepancy between ultrasonographic and radiographic findings in children who have been treated for DDH. And the question they're asking is whether hip maturation on ultrasonography is consistent with radiographic hip maturation. So like all DDH papers, it's I'm sure some of you would have heard about this term of going down the rabbit hole, and it's used to refer to a bizarre, confusing, or nonsensical situation from which one is finds it difficult to extricate oneself. So this is the typical experience of reading any DDH paper, is that you go down a rabbit hole. So with that introduction, so ultrasound and radiography are complementary tests for DDH diagnosis and follow-up. Obviously, because when we do pelvic harness treatment, we use ultrasound to monitor progress. And we also use it to define the endpoint of treatment. And convention dictates that when the alpha angle exceeds 60 degrees, we consider it as a normal hip. These authors from Turkey found that many hips that they had treated, which were mature on ultrasound, subsequently had radiographic dysplasia. So they designed the study to compare ultrasound and X-rays in children who were treated for DDH. And this was obviously in children prior to walking age. So these were all children who were treated with a abduction splint or a pelvic harness, though that's not mentioned in the paper. So fairly decent cohort, 280 infants who had graph 2B and above. Patients were collected over a 12-year period from 2006 to 2018. They excluded syndromic hips. And they looked at the data that they collected was based on clinical criteria. They classified the hips into the 4 categories, which we all know: normal, Barlow positive, Ottoloni positive, or irreducible. According to the, by ultrasound, it was classified by the graph method from graph type 1 to type 4. And in children who are older than 6 months of age, at presentation, they also did a hip X-ray and calculated all the usual parameters for acetabular dysplasia. And they also looked at what were the factors that influenced the development of acetabular dysplasia, persistent acetabular dysplasia, in hips that had a normal ultrasound at the end of treatment. So they basically wanted to define this better. Which of the hips that had a normal ultrasound at the end of treatment eventually went on to have persistent acetabular dysplasia, so that they can identify this cohort of patients, so that that cohort can be followed up more closely. And these were all the factors that they looked at. They looked at the graph type, the site, what was the initial physical exam, family history, gender, age of diagnosis, duration of treatment, etc., etc. So in the demographics, there was nothing interesting, just lots of girls and a few boys. Based on ultrasound, they found that out of the 280 hips, 110 hips had frankly dislocated hips. These are the graph type D, type 3 and type 4, and 170 of the hips were just dysplastic. These are the type 2B and 2C hips. The mean age of diagnosis was 3 months, which I think is fairly okay. I mean, it tells you that they had a standard cohort of children with DDH. The mean duration of treatment was between 3 and 9 months. So that's a fairly wide range. And the exact details of what treatment they did is not specified in the paper. So I think I would have liked more detail about why in some children the treatment was as long as 9 months, particularly because you know that these are not hips that have been treated by closed reduction. These are just treated by some sort of abduction splint or Pavlik harness. Now, some of these children also had further treatment. After the Pavlik harness was discarded, there was a further treatment of 2.42 months, which I again don't understand. And their minimum follow-up was 12 months, which I think is inadequate for a DDH study. So this is the main, the next table that appears, table 1 is the main result, where they compared ultrasound and radiography head to head. So the two things they said was, if you have a normal radiograph, none of the children had a pathological ultrasound. So that is a useful thing to know. So if you have a normal radiograph, your ultrasound will be normal. But if you have a normal ultrasound, you can still have a pathological or an abnormal X-ray. And in this cohort of 280 patients, 38 of them had a normal ultrasound but an abnormal X-ray. So looking further and following this group of 38 hips that had a normal ultrasound but abnormal X-ray, only 6 of these ended up having persistent acetabular dysplasia on long-term follow-up. And the two factors that predicted persistent acetabular dysplasia in this 6 patients out of 38 hips was the graph type and the age of diagnosis. And it's a little counterintuitive because the graph type that actually predicts that you will have persistent acetabular dysplasia is actually a 2C hip, this group. The 2C hip is the one that would predict you to have persistent acetabular dysplasia, not the higher graph grades of type D3 or 4. And a younger age of diagnosis was more predictive of having acetabular dysplasia on follow-up on X-ray. So those 2 points are a little counterintuitive, and I don't know whether it's just because methodologically there's something wrong with the study, but that doesn't doesn't stand to reason, or it's a little counterintuitive. They've also proposed one concept called the age-adjusted alpha angle. And age-adjusted alpha angle means that you just don't take one alpha angle of 60 degrees as being representative of a mature hip, but then you need to follow them up and you need to be more nuanced in what the alpha angle should be at final follow-up. Maybe you need an alpha angle of greater than 60 degrees in certain children, and there are lots of papers on this as well. So this is again this rabbit hole concept. Once you get into DDH, there are papers and papers and papers that suggest sometimes very contradictory things. So my take on this paper is that it defines a very well-known fact. All treated hips, regardless of what your ultrasound shows, they all need radiographic follow-up to maturity, or at least until radiographic maturation. And it's again, it reiterates an already well-known fact that a small number of hips that are sonographically normal at the end of treatment, at the end of Pavlik harness treatment, your sonograph is absolutely normal. It's a type 1 hip. But these hips, some of them will go on to develop late acetabular dysplasia, and some of them may need intervention. So don't discharge at the end of Pavlik harness treatment. Even if the hip is sonographically normal, you cannot discharge these patients from long-term follow-up. You have to follow them up until they are radiographically normal, or preferably until maturity. And there is a very good paper from Southampton, which I would recommend everyone to read, JBJS 2002, that shows the natural history of DDH after Pavlik harness treatment. So, paper is open for discussion.
Ajay, thanks for really going deep into this paper. Yeah, if there are any questions, please people can ask. So one of the observations, Jayan, which you brought about is if a child is, say, Barlow positive, okay, which is unstable hip, but if ultrasound is normal, there was a discussion happening in the DDH group of which has been led by Dr. Alaric, and Posi is part of this study, where what do you do to these hips? Or if there is high risk factor, but if ultrasound is normal, are you going to discharge this patient? And in the questionnaire, Delphi questionnaire, which is coming up, there was a suggestion that if you have a high risk factor, so for example, firstborn female child with breech delivery, but if ultrasound is normal, discharge that patient, so you don't have to see that, further. But you brought out a very important point that with even ultrasound normal, some of the patients can develop a late DDH. And then this should be looked for, if, so it depends on the size of the sieve, that how many your thrash is going to be, allowed to go in. So how many hips you are going to miss will depend on size of the sieve in screening program.
Absolutely. So it is how much bang will you get for your buck? So if I have to take 1,000 X-rays to diagnose one DDH, I think that cannot be justified in a screening program. And we have to accept that, yes, we have to let go of that one child, and hopefully that one child will present at some stage and we'll do open reduction on that child. And all screening programs, selective ultrasound screening programs, have shown that it does not reduce the risk of late presenting DDH, because most of the late presenting DDH do not have risk factors. And that is a big fallacy that many of these selective ultrasound screening programs do not acknowledge. I mean, they say it in the papers, and there is enough evidence to say that. So, but still people do it. And what is the need for a selective ultrasound screening program? Because you want to reduce the incidence of late DDH.
Right.
But then they'll go on to say most of the late presenting DDH don't have risk factors. So if you don't have risk factors, they will not be picked up in a selective ultrasound screening program anyway. And this is a fundamental fallacy of DDH screening programs that nobody has satisfactorily explained to me.
Right.
And they always try to dodge this very fundamental issue. They try to dodge it. Yes, but that's the fact. That's what the evidence says.
And even, that's true. And even in children where ultrasound is normal, you can still get dysplasia. So, there are a lot of loopholes, which people can cross over, where patients can cross over. And the tighter you make screening program, it's more difficult to implement. Looser you make it, you miss certain cases. So I think you have to balance somewhere in between.
So I just like to add, as Jayan sir said,
Like when they have compared even countries who have complete screening, means screening for all children, like Austria and all these countries, as compared to selective screening, they've still found the rate of the late presenting, that 1 point whatever case, is still same. So even though they're screening all or selective, either way. So I guess it's again, as you said about screening, like do we get x-rays for all of these children or every baby at a certain age to make sure they don't have dysplasia, or you let them be and they come back at some point where we treat them?
So Avi, you will get a Nobel Prize if you have a non-ionizing, a mobile application where you can, can get an X-ray vision of the hips and say whether this hip is normal or not. So finally, the answer will come from imaging rather than clinicians.
Correct.
Yeah.
Yes.
But the problem again is the logistics of making sure that every child who is born in the country undergoes that investigation at the right age. And logistically, it's a nightmare. It's a nightmare to do.
So imagine if there is a mobile application and every time a child is given a polio vaccine, that image is available, which is processed through artificial intelligence and tells you whether the child has hip dysplasia or not. But it's too much of expense to just for the condition. DDH is not the only problem. Yeah,
if you
Rajesh.
make it a part of like a immunization program, the child is going to get the injection at that time. And in India, I think availability of X-ray is more than ultrasound. So getting an X-ray is still easier as compared to getting ultrasound done, and that too a good quality ultrasound is required for DDH. Not a regular ultrasonologist might be able to do it.
So we had done a study on called "Who Missed My Hip," and our revealing things were that even on X-ray, frank DDH was missed. So recently, there was a pediatric meeting where I presented on common gait abnormalities, and I did show a case 3-year-old with waddling gait, and then showed that this is X-ray. But it's not very easy for even pediatricians to pick up a frank hip dislocation on an X-ray because they are not trained for that. They don't see that every day. They're not used to seeing hip X-ray. It's similar to, Jayant, if you or me were shown a chest X-ray with a coin lesion, how many of us will pick it up? Or if there is a coarctation of aorta, I don't know how many of orthopedic surgeons will pick it up. Or even dextrocardia. We can't even diagnose dextrocardia. We put the X-ray other way around. And thinking that the marker was put wrongly, So these things are issues. But one question I wanted to ask when we are talking of maturity of the hip, by what age the femoral head is sufficiently ossified for you not to allow an ultrasound? What is your cutoff age for that?
Around 8 months.
8 months.
Around much beyond 8 months, it's very difficult. But in the DDH hips, we have a little bit of a cheat because there is delayed ossification. Because it is the ossification of the femoral head that prevents us from getting a good ultrasound. And because in DDH hips, their femoral nucleus ossification itself is delayed, it allows you to follow them up sonographically for a longer period of time.
Okay. One more area of study here is, development of the ossific nucleus. It becomes eccentric in DDH. If you see a normal development of the hip always develops in center and then grows around it. And in most of the DDH hips, when I've gone through the X-rays, I see the ossification comes either medially and that may suggest a subtle AVN possibly in those patients.
Yeah. So that's why I put that rabbit hole thing.
Yeah. Very interesting.
Fast and straightforward.
Yeah. So more you know, more deep you go, more confused you get. Right?
Absolutely.
All right. So thanks, Jayant, for that paper, and thanks everyone for attending. And especially, I want to thank Ortho TV, Neeraj and Ashok, because now this is also gone live right now on Ortho TV. And I see that there are a lot of people who are attending this meeting on Ortho TV right now. And I also see that the number keeps on increasing. So we meet again next Tuesday. And again, I want to just tell everyone who is part of this meeting or who wants to become part of this meeting is that if you have any suggestions for a paper to be reviewed, if you want to review a paper, or like how Rajiv Negandhi did last time, he did a specific session on Sprengel, which was really good. So if anyone has any suggestions, feel free to write to any one of us. My email address is taralnagda@gmail.com. So write to me and be part of this club. Thank you everybody for joining. I see Saeed Ahmed from Pakistan also here. Saeed, hi, thanks, good morning, and thanks for joining today. So with this will end. It's just 2 minutes to 8. It's time to go back to work, and see you next Tuesday.